What was the impact of this service?
So a very positive one, I would say. We, as a service, had 300p referrals within the calendar year of September 2022 to the end of August of 2023. Makes up just under 50% of the total referrals to the service. The most positive aspect, I would say, is that of those 300, 89 of them were managed as ambulatory patients from day one. So that places around about just under 30% of the PE cohort that we saw, which is good because that's in line or close to what was estimated from things such as the BTS report of what should be ambulated within the UK. And those patients then all 300 of those patients were in the system. But going back to those 89 patients that we managed as ambulatory patients, we did a little bit of an evaluation looking at complication rates. And thankfully, we had a very low rate of 30-day readmission. So only 4% of our patients were readmitted to hospital within those 30 days for complications of their PE. And that's really positive because ultimately the aim of this is that we can safely manage patients as outpatients, and that data has obviously shown that that is the case. Likewise, we also looked at the end product, which was how many of these patients required subsequent referral onto respiratory, because, as I mentioned earlier, we have a pathway with our respiratory colleagues whereby if there are patients with ongoing dyspnea, which is affecting the quality of life, or if we undertake echo where there are concerns about pulmonary hypertension being present, we refer to respiratory. It was only 3% of the cohort that needed that referral as well. So again, the idea is that these patients who are managed and recover well and don't seem to have any complication, they were being kept out of those highly specialist services so that they could focus on the groups of patients who do need that specialist input then.
So does this mean that about 1/3 of the patients have been taken out because you've demonstrated that this can be done safely? And so specialists' time can now be devoted to the more serious cases?
Absolutely. And what we're talking about as well is prevention of admission, because it's not just the idea of things such as bed days being saved. It's not just the experience of the patient in general, but it's also the idea that these patients are not being put into that classical admissions unit waiting room. They're not being put in that stack of patients who need nurse assessment at the front door, who need medic assessment. These are being managed via ambulatory pathways, meaning that they're taken completely out of that, which is naturally a positive thing. But as I mentioned, I think that one of the key aspects of the service that really supports with this is the 7-day review, because actually, I mentioned earlier, with these patients with the lower risk PEs, it's still a very, very concerning event for them. And from an anxiety perspective, it's quite a lot of anxiety for a patient with a PE. So having that 7-day review is really useful from that perspective, because it allows them to be seen within 7 days, so that then they feel at ease. They're getting a full clinical assessment. We work within an SDEC with a variety of specialities, with medics, with consultants. We have immediate access to them if required, if we feel that there are complications developing, or if the patient is declining in their clinical status. So again, we've got that nice secure system to allow us to manage these patients effectively as outpatients.
How did the doctors react to this?
Yeah, I think that's a very good question. In relation to your first question around the medic response to this, very positive, in fact. As I mentioned earlier, within our same-day emergency care unit, our SDEC unit, we work as part of an MDT, which is primarily medics. Primarily senior medics, in fact, senior GPs and consultants. So we were already embedded within that team, and naturally they were aware of what we were doing, and they're aware of what we could do. So we've always been very supported within that team.
And were there any special challenges that you faced?
Oddly, I would say that the greatest challenge came from myself, if I'm completely honest, my own internal challenge, because I was very keen for us as pharmacists to focus on what I feel our skills are, which is fundamentally in therapeutics, and ultimately VT in general is primarily a drug managed condition. And especially in the groups of patients which we're talking about, these lower risk outpatients. But I feel that it's a slightly more complex condition to understand what a good outcome looks like in terms of therapeutics. And what I mean by that, there's various different things that we're looking at with these patients. So I felt that what we needed to do was to actually do some internal development on our advanced practice skills to ensure that we were able to evaluate these patients efficiently for what a good outcome looks like. And what I'm talking about there is things like patient assessment, respiratory examinations, echo assessments and such. And like I said, I was very keen that we not move away from the core skills that we have as a pharmacy team, but instead that we actually add things on to our skills to make us better as prescribing clinicians within that area. So as I mentioned, I think probably the biggest challenge came from myself more than anyone else. And we've developed a framework now for how we practice, which is good. I think we're the only groups to have a defined framework which has been developed for practicing within this area. And we've developed quite an extensive training program as well, which has been really good.